So on to our next presentation, and I'd like to welcome Charlotte McLennan to the stage. She's going to tell us about her Protect project, Falls Prevention Program, early implementation results from her stepped-wedge hybrid Type 2 Effectiveness Implementation Cluster Randomised Trial. Goodness me. It was a little bit of a mouthful, and then you're going to hear from the teams that participated in the trial afterwards. So I'm going to hand over to Charlotte to finish up today. Thank you.
Thanks, Bryony. Thanks, everyone. Good to be here. So, yes, I want to acknowledge that this is a big team effort that have been involved in this work, and so some of the investigators are listed there, but we've got a broader investigator team of consumers and, of course, of all of our wonderful clinicians that have been involved across SLHD. So, I'm not going to go into this. Bryony spoke to it so well. We have our falls in our hospitals across Australia are increasing. We can see the data is showing that. And we know that this is because of our increasingly complex patients. The average age of inpatients is increasing. They've got more complex comorbidities, and we're seeing more cognitive impairment. And as we've also discussed today, we know that there's promising evidence for multi-component, multifactorial interventions, so sort of bundle approaches. There's no one silver bullet. We need to be thinking of a lot of things. But we unfortunately don't have really rigorous evidence to support these multi-component, multifactorial interventions, especially in acute, really complex, diverse settings in which we all work. And we need that really rigorous evidence to give us the best bet to secure funding to support these initiatives. We also don't have rigorous evidence really looking at, well, we know, multi-component fall prevention interventions are working, but what can we do to help support staff to be embedding these into routine care? And so back in 2023, a group of organisations came together to submit for a grant to try to provide more rigorous evidence to support approaches to multi-component fall prevention interventions. And so this was through the University of Sydney, through Sydney Local Health District, where I work, and through Southwestern Sydney Local Health District, who have really led the way with implementing a lot of improvement science approaches to, improving patient care more broadly, and certainly then the CEC, who, lead a lot of the work in guiding us all with improvement science and quality improvement initiatives, across settings. And so with this grant, what it enabled us to do was really initially spend some time coming up with the optimal design of a program that we wanted to test and roll out across a health system. And so we conducted qualitative studies where we interviewed staff across our health district, but again, speaking to staff that had been involved in the successful initiatives in Southwestern Sydney Local Health District, and also spoke to staff across Australia that had been involved in programs looking at improving care for older people more broadly. We had a lot of consultation with our stakeholders and partnered with as many groups as we could across our health district especially, just to really ensure we were trying to design a meaningful and a practical approach to fall prevention for our district. We then also needed to design methodology that was really rigorous, that would give us the best bet of, a rigorous evaluation of the program. And so Professor Cathy Sherrington has led this, and she has led the grant, and it's involved researchers from across Australia in coming up with this trial design. And so, as Bryony said, we've got our stepped-wedge design, but that's there, and I'm going to go into it again in a moment, but we've also got both an effectiveness and an implementation angle. So we're looking at both, well, what's the effect on falls, but it also allows us to look at, well, what are we doing to support the interventions in actually being embedded? In terms of our outcomes, so with these research-style projects, we do need to decide on one primary outcome, and so for our work, it's looking at the rate of falls per 1,000 patient bed days. That will be the ultimate primary outcome that we look at. But then we've also built in a lot of secondary outcomes to look at the broader impacts of the program, so things like risk of falling. So that's rate of falls is just the sheer number of falls, and then when we talk about risk of falling, it's the number of fallers, so, capturing more those repeat fallers. Looking at injurious and unwitnessed falls, hospital-acquired pressure injuries and delirium. Importantly, we're looking at patient activity levels, so we don't want falls to be reducing at the cost of then patient activity. So, it's all well and good to say we had no falls, but that's no good if it meant that no one was up and about either. We're looking at staff professional fulfilment, and again, at those implementation outcomes and determinants to tell tell us, well, are multi-component interventions actually being embedded, and if so, what's supporting that to be done, to happen? So, the intervention in our program. Ultimately, the intervention is multi-component fall prevention interventions, but the wards that have been involved in delivering these multi-component fall prevention interventions have received local data to inform the design of their own tailored fall prevention interventions. And this local data is both their incident data, so the wards that have participated in our program received a summary of their IMS data, looking at trends around their falls, but also staff surveys, patient surveys, and staff brainstorming sessions to really work out, well, what's leading to the falls in our ward. Then importantly, we had our implementation strategies that were supporting staff to embed their fall prevention interventions. And this was really underpinned by quality improvement and improvement science training, and underpinned by the Clinical Excellence Commission's approach to this. So the wards that participated in our program were encouraged to send at least 2 staff members to the 2-day improvement science course that was the CEC's course that they model that was available through our Sydney education program. Here at the course, staff could brainstorm the problem of falls on their wards. They were around developing driver diagrams and learning around testing, conducting small tests of change through PDSA cycles, very similar to the approach we saw Lucy and the team take earlier. Really importantly, and probably one of the most important implementation strategies we had was the clinical facilitation provided by the wonderful Sally Delaney in our team. So Sally's position was established through the grant, and that's a full-time 1 FTE position. And Sally would work with 4 wards at a time for 21 weeks. So they'd have 4 weeks where Sally was sort of more orientating the ward to the program again. We'd often call it the warm-up period, these 4 weeks. We'd be collecting staff and patient surveys, letting staff know the program was about to happen, and then there'd be 7, and in that 4 weeks, that's normally when the staff did the improvement science training, and then we'd have 17 weeks where Sally was really intensively working with the ward to help them decide on the main change ideas they wanted to focus on and help them embed them. And so, it was various support, such as helping design tools to monitor the change ideas, lots of education to myself included on the quality improvement dashboard system, and really importantly, working with the teams to celebrate wins. We also had fall prevention education and training for as many staff on the participating wards as possible. And so in the early days, this was really more generic around, well, what are the main risks for people falling when they come into hospital, and what are the ongoing consequences, really reminding staff of the long-term impact even a sort of what looks like a simple fall can have. And as the teams progressed into their 21 weeks, the training sessions became more specific to the change ideas the teams were focusing on. We also, importantly, were building a coalition, which is what everyone's speaking to today, getting as many people on board and, creating buy-in from as broader groups as possible. So, in terms of recruiting, how do we get our wards to participate in the program? So back in August 2024, once the trial and interventions and implementation strategies had been designed, we set up an expression of interest process, and this is all also happening via ethics. So there were, it was a long ethics guidelines and within ethics timeframes as well. So this was sent across to the 4 inpatient facilities in our health district, and wards could put an expression of interest. They were encouraged to select a multidisciplinary team. They needed executive support to sign off on the EOI, but it was pretty simple what they had to write in. And so we had 19 applications at this time, which was really promising, and of them 12 wards were selected, and it was really based on getting a diverse case mix and then also prioritising wards that really seemed to be able to have multidisciplinary involvement. From a research perspective then, what we needed to do was cluster the wards to start the program at one of 4 time periods to do that stepped-wedge trial. And this was a real challenge for our wards. They had to put their hand up and say, well, I'm willing to participate in this program, but I have no idea when I might have to start it. And so, it's a credit to the teams to put their hand up under those circumstances. And so if we come back to our trial design here, you can see that we had those 4 time periods where the wards had sort of 4 to 5 months, that 21 weeks of intensive implementation support, and then Sally and the teams would move to supporting the next 4 wards. So We've had all of our 12 wards now participate in the program in that intensive implementation support, and we had these wards from across 4 hospitals, both acute and subacute hospitals, and you can see we had a mix of specialties and we had a mix of surgical and medical wards and rehab and, acute wards as well. 9 of our 12 wards had multidisciplinary leadership, which was really great. 11 of our 12 wards were able to complete the face-to-face improvement science training, and our 1 ward that didn't, it was really, it was really tough. They had SNAP accreditation time on the occasion of the first course, and then they'd rebook to attend at another time, and it was the nurses' strike. So it was really bad luck for them. They really tried to get there. And then 12 out of our 12 wards did complete that intensive clinical facilitation period. In terms of the data that we're collecting to inform this rigorous evaluation of the trial, we've so far collected 383 staff surveys, we've collected 308 patient and carer surveys, we've conducted 27 interviews with staff involved in the program. We've conducted 28-hour audits on the participating wards, and these are patient activity audits where we really just go around to the bedsides over and over again, noting the activity levels of the patient. So is the patient in bed? Are they out of bed? Are they walking around? And that's really our measure built in to make sure that fall prevention is not at the cost of patient activity. We've also been able to conduct implementation audits on all of the wards, so looking at, well, what the change ideas that they've said they're doing, that they've said they're wanting to implement, are they being implemented? And we are now waiting for that ongoing routinely collected data to come through. So because this is part of a trial, we need to wait until we've had 4 months after that final group have finished before we can pull that big data set of both coded data and our incident management system data to evaluate the program from an overarching aspect. But more excitingly, that's the end of my talk. But I wanted to say again a big thank you to everyone that's been involved. It's certainly a team effort. And we are now going to move into the much more interesting and exciting bit of our session this afternoon, which is where we're going to hear from some of the wards that have participated in the program. They've worked incredibly hard. They've, absolutely, as they always do, have optimised patient care and had patients at the centre of their care. And, this has been amongst challenging circumstances. They didn't get to pick the ideal time. There's been staffing changes for some of the wards. It was a different, leader that nominated versus who was there at the time when it was their allocated time period. There's been hospital redesign. We've gone through winters, closures over Christmas periods and things. So it's a real credit to them, all the work that they've been able to do. So I'm going to hand over to them now, and I think I'm going to introduce them as we go. So I'm going to bring our first ward up, which is 2A. An acute, I'll let them introduce themselves, but we've got Jack and Eleanor from 2A at Concurrent Hospital. So I think you guys perfect.
Hi everyone, my name's Jack, I'm a physio, and this is Eleanor, our acting NUM from Ward 2A. So we are an inpatient acute aged health ward from Concurrent Hospital, and this is part of our involvement in Protect with our title calling Fall Free from A to B. So just some context, we are a 24-bedded ward in the new part of the hospital, and with this, although it's beautiful, it is very spread out with poor lines of sight, and there's also no 4-bedded bays, so we're predominantly single rooms, and we really did have a big MDT ranging from nursing staff, allied health, all the way through to executive.
Thanks, Jack. Prior to the Protect program, 2A had a high number of falls, with an average of 8 falls per month in the period spanning from January 2023 to December 2024. This is due to our cohort, confused, reduced mobility, frail, the list goes on. 70% of falls on 2A were unwitnessed, with key times being between 8 to 11 a.m. and 4 to 7 p.m. Our aim was to reduce falls by 10% by the end of August 2025.
So how do we go about this? As Charlotte had mentioned, we had 4 months of intensive support from the Protect program. And then a few of us did attend that 2-day improvement science course. And a lot of our interventions were revolving around that, where we designed and rolled out tailored fall prevention interventions in conjunction with the MDT. Our initiative included surveys, audits, education sessions, PDSA cycles, data entry and review. And we did a lot of this data recording through the CEC's quiz suite, which Charlotte mentioned earlier as well.
So 2A trialled and measured various change ideas. We had patients sitting out of bed for main meals, where we would offer toileting, ensure their valuables and buzzer were within reach. We had physio-led CEC Give It a Go education. This education encourages staff to get patients moving prior to a PT assessment. We implemented MDT post-fall huddles. This is an interdisciplinary approach post-fall where we discussed what may have contributed to the fall and can identify any key lessons learnt. We optimised consistency of patient mobility reporting, aiming for consistency between the latest physio note, the patient's communication board, and the nursing handover. We had nursing staff education and quizzes on delirium, the safe use of bed rails, and falls prevention and management. This aimed to increase awareness on policy-driven falls prevention. We improved the processes for after-hour bed allocations for high falls risk patients. This is a step-by-step reference guide for the nurse in charge to assist with allocating patients in high-view bays whilst avoiding too many bed moves, which we know can spark delirium and confusion in the elderly population. This guide has been shared across Concord Hospital, and I'm happy to share it on a wider level. We completed audits of continence pads and falls alarm use, including our specialised alarm beds that can detect when a patient is trying to get out of bed rather than when they have already stood up. This comes hand in hand with the after-hours bed allocation process.
So what did we learn? During the Protect project itself, we had a reduction in falls per month by 37.5%, going from 8 to 5, well exceeding our aim of 10%. Post-Protect, we have maintained a 25% reduction in falls per month, with our current average being around 6, and now our long-term average since July 2024 is now 6.4 falls per month. Separate to the falls, post-Protect, 100% of our staff reported understanding their role and feeling confident in undertaking hospital fall prevention interventions.
In conclusion, our project supports existing evidence regarding the benefits of implementing tailored falls prevention interventions created in conjunction with the multidisciplinary team. 2A is persisting with the implementation of change ideas that we have found to be the most beneficial. Through this process, we found that sparking a conversation empowered our staff to take a more active role in falls prevention. Thank you to the Protect team for guiding and supporting us. It's been a privilege to be part of the project.
So next up we have Renee and Stephen representing Lever Ward at Balmain.
We'll do that one.
Go for it. So. All right, hello. So I'm Steve, the nursing unit manager on Lever Ward, and I've also got Renee, who is our senior aged care physio at Balmain Hospital. Oh, it's going.
There we go.
We're back, no worries. So just a little bit of background, I guess, about Balmain Hospital and Lever Ward in particular. It's a subacute facility. Lever Ward is one of 2 aged care wards at Balmain. 28 beds on the ward. It's definitely an older hospital, so the layout is not ideal, let's just say. Lots of corridors. I think our nurses' station is next to absolutely none of the beds.
No, the gym.
It's good fun. Yeah, it's good fun. We like it. So I guess as a background, the majority of our patients are going to be admitted directly from RPA Hospital, sort of the major tertiary facility in the area. And I guess historically the main drivers of the falls were cognitive impairment, dementia and delirium, just general poor mobility and general frailty. Pre-Protect, you can see that we were averaging about 4.5 falls per month. And it fluctuates. I think with falls, it's important to note, and I think one of the main benefits of the Protect project was getting access to that 2 years of historic data, because you can be sort of victim to small sample sizes. So being able to look at 2 years of data was very helpful. So we'll move on to this very simple driver diagram. We hardly even need to go into it. But all kidding aside, this is something that we were able to generate in the Improvement Science workshop, which I think Lever Ward, one of the reasons why we were so successful is we got a large buy-in from a variety of staff across the MDT, and we were able to sort of gather all these great ideas and then transition it down into what turned out to be primarily tangible changes that we were able to implement. So I'll pass on to Renee, who can talk about some of those.
All right, so what were our ideas? We had lots of ideas and we implemented quite a few things, but the three key implementations that we made were sitting patients out for bed and also toileting them. We started with just doing breakfast, and then that worked well, so then it included lunch, so patients sit out both for breakfast and lunch on Lever Ward. My personal favourite and my baby was allocating individual mobility aids to patients. So rather than sharing mobility aids, they each got given one and it had their name on it. We started obviously on Lever Ward, but that now is a hospital-wide thing. Every patient at Balmain Hospital gets an allocated frame, and we started that with the Protect project, which was really good. The other really big thing was uncluttering the bed spaces, and that was multidisciplinary. It's not just the nursing staff, but it was me after seeing a patient making sure, and everyone that sees a patient, when you leave them, it's not cluttered any longer. One of the things brought up was, frames clutter the bed space. But now that we allocate frames to patients, the frames just aren't kept in the middle of the room anymore. They're actually at the end of the patient bed because they're actually allocated to a patient. So that's a bit anecdotal now, but I've noticed there may be more frames in the room, but they're actually at the end of the patient bed, so it actually declutters the space. On to the results and the good stuff, if this works. I'm frozen. There we go. So we had a 48% reduction in our falls, which was great, but what I think is really important and something we're very proud of, and the whole of Lever Ward and Balmain Hospital is proud of, is we've maintained that reduction for 17 months. So for the last 17 months, we've had a 48% reduction in fall, because it's great to reduce your falls, but you've got to maintain it. It's the sustainability that's really important, so we're really proud of that. On to conclusion. Engagement with the initiatives was really because they're real hands-on things. It wasn't like making policy, procedure changes. It was like, right, you just physically do this thing. And I think that's why we got really good engagement from everyone on the ward. Involvement of select keen staff. I was actually working on a different ward at the time. This came up, Steve came up to me and said, Renee, can you come back? We're going to do this project. I went, that's great. So it's getting the staff, and we also made sure that the allied health staff, while this project was happening, stayed on that ward, because we know with allied health we rotate a lot. So in order to embed these strategies, we made sure that the allied health staff were not rotating during that time, and that was really important as well. We were quite strategic in taking quick wins. So we wanted, the momentum going on the ward, so we chose things that were relatively easy to implement, but then also we got good wins out of it, so then that kept everyone really keen to keep doing this project.
Yeah. Overall, I think the project demonstrated just the multifactorial nature of falls, which I think we've been hearing about throughout today's presentations, and that was definitely the case in Lever Ward as well. Like I was saying earlier, we really benefited from the luxury of having access to 2 years of data. As a NUM, I know that I'll look at IMS, but being able to be given a document with 2 years of data that you can actually break down and get a really nuanced idea about was really helpful. And then lastly, it seems like, and I would say anecdotally, and also just chatting with the staff, so anecdotally, the structure that has been implemented with Protect seems to be embedded, and the interventions are still strong and going forward. Just acknowledgements to the fabulous staff that took part. As you can see, there's representation across pretty much most of the disciplines in the MDT. And of course, shout out to Charlotte and the lovely Sally.
And Sally.
Yes.
It was awesome. Thank you.
Brilliant. And next up, we have Audrey. Sorry, Audrey, it's running away from me. We've got Audrey presenting for Ward 6 East 1 at RPA Hospital.
Hello, good afternoon. My name's Audrey. I'll be presenting on how we enhanced our falls prevention and management strategies in our acute mixed specialty ward. My core Protect team is a little bit smaller. It's consisted of myself and our RN Ari, but I did want to mention the rest of our staff who put in all of the efforts in implementation of changes. So a bit of background, we're a mixed medical ward, renal, dialysis, endocrine, rheumatology, immunology. Our falls drivers were acutely unwell patients, rapid behavioural changes, structural layout of the unit. Our single rooms are not at all visible from the nurses' station. Our pre-Protect data, we had an average of 4.6 falls per month. 63% of those occurred at the bedside and 70% of falls were unwitnessed. So, our methods. So we started Protect in September last year with the intensive supportive period. We were able to learn about creating change ideas using the PDSA cycle and using the improvement project in a structured manner. We decided to choose change ideas that were already easily implemented and easy for staff to provide patient education. Our first one was to focus on our curtains in our high visibility room. We then transitioned or attempted to transition this into the other bay, but despite fluctuation in the following bay, due to patient refusals or patient deterioration, we were still able to achieve 100% of curtains open in the high falls room after continued staff and patient education. Our second change idea was sitting patients out of bed, so similarly to other wards. We decided to start with lunch, purely because our staffing and night shift crossover was only 3 on night shifts. We were then able to transition that change idea to toileting prior to lunch, and then we were able to replicate that to dinner as well. Our other change idea was the reflection for staff and education, so through quizzes, utilising previous case studies, as well as utilising information from policies as well. To monitor, we were just auditing from daily, then to weekly to monthly, using surveys and reflections from staff. Our results. Since commencing in September last year, we've been able to reduce our falls an average of 3.3 falls per month. That's a 28% reduction in falls. We've decreased in unwitnessed falls of 14%. 100% of our staff that we had surveyed during at the end of the intensive period felt that they were confident in undertaking fall prevention interventions. We have an increased awareness, patient awareness of change ideas. This is due to our display of our Protect board at the front of the ward, as well as allowing staff to refer to it during education. In conclusion, small changes have a big impact. To help with that snowball effect, we've really needed our leaders and teams to be united. So without our NUM assistants in providing time and conducting and implementing these changes, without Charlotte and Sally with supporting and providing structure, and without the staff putting in that effort of implementation, we wouldn't have had these results that we did. It helped our staff feel more confident in falls assessment and patient education. It created a greater sense of staff pride and achievement, and again, more informed patients. From here, we've increased our immediate Protect team. We've onboarded another RN to manage a change idea based on decluttering twice weekly. We have continued ongoing education of staff on falls prevention and monitoring ongoing to ensure we have sustained changes. That's about it.
have, thanks Audrey. Oh, sorry, I'm too buzzer happy. Okay, now we have Ward 2B, the B of A to B, Arpana, Priya and Deepak.
This is next, is it? Hello everyone, we are representing Ward 2B from Concurrent Hospital. My name is Deepak and I'm joined by my colleagues Arpana and Priya. To provide some context, fall prevention is persistent challenges within acute geriatric ward. In Ward 2B, most of our patients are at 65 and older, often presenting with complex conditions such as delirium, dementia, and chronic confusion. These factors, combined with compromised mobility and cognitive impairments, significantly elevate the risk of falls in clinical settings. Before we implement our current initiative, we recorded an average of 9 falls per month over a 12-month period. Critically, 82% of the falls occurred at the bedside. Furthermore, 75% of these incidents are unwitnessed. Based on the data, our primary target was to reduce the fall by 10% by August 2025. Today, we will talk about the strategies we use to work towards that goal. Priya will cover the next.
Our PROTECT project started in April 2025 with an intense period of 17 weeks. We adopted a multidisciplinary approach to work on our PD essays. The first key change idea during this project that we brought was introducing the safety cross falls calendar, so marking red as the falls day and the green as the no falls day. Secondly, getting patients' family or carers to bring in a suitable footwear for them while they're at the hospital. The third thing we introduced was introducing the monthly post-fall reflection, where staff will gather together and then brainstorm on risk factors and preventative strategies, which we could apply for a similar situation the next time. The other change idea we brought was sitting minimal assist patient up on the chair during lunchtime. The next key ideas that we also brought was providing education session on 480s and involving staff to do knowledge quizzes, which was based on local district policies. We also introduced individualized toileting plans for highly agitated and impulsive patients. And lastly, our 2 PDSA cycles involve physio and OTs. So physio provided the CEC Give It a Go education session to ward staff, which focus on early mobilization to prevent deconditioning, eventually with the aim of reducing falls. And then OT was involved with patient chair height adjustment education session, which was provided by the OT, as I mentioned, and then auditing was conducted prior. To monitor and evaluate our key change ideas, we conducted regular audits and incorporated those data in quiz. The attendance of all the post-fall reflection sessions were also uploaded on quiz and filed in our ward in-service folders as well. Now a quick glance on our quiz data. So this graph represents the percentage of our patients having suitable footwear during that time period. This graph shows the percentage of patients sitting up for lunch in Team A and then Team B. It's not working. Okay. And this graph represents the percentage of staff who have attended the quizzes, which we're very proud of, as more than 85% of our staff attended the quizzes. And it's an ongoing plan, especially with new grads upcoming, and then also with new staff joining the ward. Thank you.
Okay, let's see our overall result of this project. So after the project, we have achieved up to 12 consecutive falls-free day in May and December. I know it's not a big one, but it was very encouraging progress for our ward. There has also been a clear improvement in staff knowledge, especially on the safe use of bed rails, as well as better recognition and assessment of delirium with more timely escalation. Importantly, the survey data showed that the staff confidence level in in applying wide range of strategy has improved. It improved to 83% from 63, which is a significant step forward for us. So looking at this data, the average number of falls per month between May 25 and February 26 was 7.5, which reflected 12% reduction in our monthly falls over that period. And this suggested that our PDSAs that we applied has a measurable impact. We have seen a strong compliance in suitable footwear use, with over 93% of patients consistently being provided with appropriate footwear. In addition, our CNSs and senior nurses has been actively involved in monthly post-haul reflection, helping to identify learning opportunities and reinforce best practice within the team. Through our Give It a Go initiative, staff has now developed confidence in safe and timely patient movement prior to the formal physio review. In addition, ongoing knowledge quizzes had a positive impact on staff understanding, particularly in relation to the appropriate use of bed rails. So the lesson that we have learned is a multidisciplinary approach with clear communication and shared accountability is essential. Active teamwork along with ongoing staff education and engagement drives better outcomes. So the key take-home message is falls prevention is everyone's responsibility. Early identification, strong teamwork, and consistent interventions are what we're truly making the difference. Thank you.
Brilliant, and I know we're getting very close to time, so this is our last group up now, 8 West 1 from RPA Hospital. We've got Lockie, Faith, Karen and Bella.
Thanks, Charlotte. My name's Lachlan, and this is 8 West 1's orthopaedic Make It or Break It team. Our pre-Protect data showed on average we had 4 falls per month from September 2022 to September 2024, with 39% of those patients having impaired cognition, confusion or behavioural disturbances. As a lot of the other teams mentioned, we attended a 2-day workshop, improvement science, in which we came up with our AIM statement, which is below, which our aim was to reduce falls in cognitively impaired patients by 20% in June of 25 and reduce falls by a further 10% by June 2025. This came up with our change ideas after lots of work with our PDSA cycles. We came up with 4AT screening to be completed within 8 hours of admission, delirium detect training for all staff, delirium information brochure teach back viva voce, and reducing our environmental falls risk.
So to support our aim of reducing falls in cognitively impaired patients, we focused on early detection of delirium through the implementation of the 4AT screening tool, which was our first change RD. Previously, the 4AT was completed within 24 hours of admission. However, we decided to shift our completion to within 8 hours of admission, as this allowed us to identify at-risk patients early and then implement targeted interventions. This was also supported by clinical staff participating in theory-based education that outlined the risks, prevention, the importance of early screening and diagnosis, as well as management, and as well as providing patient-centered information and support. As a result, our 4AT compliance rate improved significantly from 20% at the start of the project to over 80% by the end of the project. This played a key role in reducing our falls and enhancing patient safety in our cognitively impaired patients.
To further support early detection and prevention of delirium-related falls, we implemented change IDs 2 and 3, which is detect and teach back. Under detect, we focused on simulation-based training and role play for all multidisciplinary team using orthopaedic-specific scenarios to reflect the real patient presentation. So, for example, the photo. This hands-on approach helped staff recognise delirium symptoms more confidently in practice, and we achieved a strong engagement rate with 90% of staff attendance, which was a key to building capability across the team. The teach-back strategy reinforced this learning. Staff were educated using the ACI delirium brochure and completed a Viva Voce style assessment to ensure understanding. Importantly, targeted individuals and their carers received education on a mission, supporting awareness and involvement in their care. Together, these strategies strengthened staff knowledge, improved recognition of delirium, and promoted consistent patient-centred communication, which contributed to the reduction of falls.
Environmental safety is a core component of preventing falls, particularly for patients with cognitive impairment. We focused on the fundamentals: keeping spaces free of clutter, positioning beds and furniture safely with brakes engaged, ensuring essential items were within reach, maintaining bathroom safety, and providing adequate lighting. To support safer care, staff carried out routine environmental checks through and kept falls prevention plans up to date as patients' conditions changed, and reinforced safe mobilization with patients and carers. These consistent actions helped reduce risk and protect patients. This project has strengthened falls prevention on our ward and contributed to a 20% in falls among cognitively impaired patients. Since the intensive phase of the project concluded, our falls have stabilized at an average of 3 per month, and we've maintained that improvement. What's been most encouraging is the flow-on effect. Our change ideas haven't just been implemented, they've been sustained. Environmental risks are being identified earlier through practical bedside in-services and informal check-ins. Clinical staff are having more meaningful conversations with patients and families about delirium using brochures and the Teachback tool. All of these reflect a team that is more aware, more proactive, and more aligned in reducing falls for cognitively impaired patients. The improvements are real, and they are being carried forward by a shared commitment to safer care. We are proud of the progress this project has supported, but even more proud of how consistently our team shows up for patient safety. That's what will keep driving these outcomes forward. A special shout out to Charlotte and for Sally for helping us with this project. Thank you.
Okay, thank you, Charlotte, and to all the teams for their great presentations. We don't have time for questions, so I encourage you to reach out following the forum to Charlotte and the teams. We're now going to start plenary session 3. Thank you.